if people can try to complain about the system, this happened and this happened and this happened, and it just seemed like staff did not have the time they needed to treat me like a human being. And if more and more and more people said that, I think it would start to make a difference. I think it's hard to feel like each of our individual voices matters, but together they get loud.
Hello, everyone. I'm your host, Dr. Shafer of Talks with Dr. Shafer. I'm so glad you're here. I'm a physician, mom, life coach, musician, author, publisher, and I'm passionate about helping others reclaim their stories so they can build their most beautiful future. And here today, we have such an inspiring guest, Theresa Brown, PhD, BSN, RN, so many wonderful hard-earned labels at the end of her name. She's a New York Times bestselling author of The Shift, as well as many other beautiful books, Healing, When a Nurse Becomes a Patient, a story of personal experience with a breast cancer diagnosis, treatment and recovery, and how patients experience healthcare in America, as well as her first book, Critical Care. Theresa, thank you so much for joining me on the show today.
Oh, thank you for having me. It's really a pleasure.
I'm so excited. We've had to, work towards scheduling this because you were on a grand adventure and now you have come back to the States, and I appreciate you making time. I hope the jet lag has passed now. It was so fun to see on social media, see some really interesting things that you were experiencing on your adventure. After having your diagnosis of cancer and publishing your books and sharing your story with the world, is it more important to go out and have those experiences now for you?
Oh, absolutely. And so people listening know I'm just lucky to be married to a college professor who, after being chair for 7 years, got a year of sabbatical, which you might feel like, wow, I've worked my whole life and never gotten a sabbatical. But it is, a bonus that university faculty get. And so I'm working on my fourth book, which I can get to also. But we spent fall in Santiago, Chile, and then we spent spring in Madrid and Barcelona. He has colleagues in both places, and it was wonderful. And yeah, if I hadn't had cancer, I might have felt like I can't do this. I need to be moored in the US. I need to be where my work is. And I definitely feel like, no, we all get one life. That's it. You don't get another one. And so when opportunity comes, take it.
I love the word you use, being moored, because then the opposite of that would be unmoored. And it's interesting that, and you were talking about, the feelings of, can I do this? And this feeling that if we leave our post,
Mhm.
that we're somehow abandoning our post and that we're unmoored. And I think that's a feeling that a lot of healthcare professionals in particular feel. There's a lot of shame that goes around being a healthcare professional and how you performed that day. Did you stay late for your shift, unpaid time? Did you do the extra charting? Did you take the extra shifts? Without really paying attention to the fact that, zooming out, as you said, this is your one life and you need to be taking care of yourself too. And is that something that you think about and talk about now that you're sharing these stories from a nursing perspective, many of your stories of that dual experience of being a patient, but also the experience of being a healthcare provider and having a foot in both of those worlds?
Oh, yes, great observations. And that's really why I wrote my third book, Healing, because when I became a patient, I suddenly saw all the ways the system fails patients. And I think everyone knows now our healthcare system is broken, and we talk about that, lots of details. I agree with that. But what I saw was something even more fundamental, which was a lack of humanity and humaneness. And I had a very treatable breast cancer. It was diagnosed very early. no one ever sat me down and told me that. I felt like it was all DIY, cancer your care, like do it yourself, which is how I
Mm,
felt. And it was so eye opening for me because as a nurse, I worked so hard for my patients, and so did the other nurses I worked with and the doctors I worked with. We all worked so hard. But suddenly I could see moments where, without even realizing it, we really let people down. And I wanted to write about that because how do you bridge that gap with this broken system that's so difficult to sometimes treat patients as human beings within? How do you find empathy? How do you come to work and show up for patients? And no one is going to do that 100% of the time. They're just not. We're all human. We're going to fail. We're going to disappoint people. That said, how can we make our system so that it's more about acknowledging people's humanity, meeting them where they are, helping them through these difficult moments rather than them feeling like either it's DIY or alternatively, sometimes I felt like I just got on the conveyor belt, the healthcare conveyor belt, and I just kind of moved along like a box on an assembly
mm,
line, um,
yeah.
which again doesn't feel personal. And I tell this story from the book a lot about a patient I had when I was a nurse had come in for scheduled chemo, which sometimes people they have to be hospitalized for follow-up chemo after their treatment. And so he'd come in for scheduled chemo and he had been told you're going to start early on, let's say it was a Friday so that you can leave early on Sunday when you're done. And great. My patient, except I could not get an IV pump for him. And people in healthcare know that's like a restaurant not having forks. It's like we just, and I called supply and there's no IV pumps, no IV pumps anywhere. And
Mm,
I kept calling and no IV pumps. And I was really busy with my other patients. And he would come to the door of his room and give me the dirtiest looks I've ever received in my entire life. Like he was
mm,
so angry. And my feeling was, I get it. I didn't create this problem. I can't fix it. And I'm really, really busy. After I became a patient, I looked back at it and I didn't blame myself or feel guilty, but I suddenly saw through his eyes what had happened. We had promised him something and we weren't delivering. We weren't explaining that to him. We weren't trying to find a way to make it better. We weren't meeting his humanity. And it's that conflict that I wanted to bring out to readers. And
mm.
it's a very hard problem.
It is, and I wonder, I'm curious to your response to this, thinking about that story and so many stories of when something goes wrong in medicine. My intuition is that the basis of most of those problems is shame.
Mm,
Medicine is very rooted in shame. The way that we are educated is very shame based. The way that medical errors are litigated is very shame based. The way that hospitals are often ran, it's, often a carrot versus a stick type of way to manage professionals who've worked really hard to earn these titles. Very hardworking nurses that are literally just showing up every day and they have no control over a lot of the things that end up dinging their records. Like, was there an IV pull? Well, there wasn't. And now I have a dissatisfied patient, and that's going to affect maybe even my salary. Right. So,
mm,
shame sounds like a big word, but I do think when you work in healthcare and you go through all the ways that we monitor success and we monitor reimbursement and we deal with consequences and reactions to incidents that occur of a broad variety, shame is at the basis of a lot of it, and retribution, rather than working as a team to problem solve, figure it out, and simply do better next time. And I know a lot of people say that they work towards that, and some institutions do, But I also know from talking to a lot of nurses and physicians and assistants that their day-to-day life, there is a fear of making mistakes, a fear of not being the very best all the time, of not knowing everything all the time. And I think when you're afraid of failure, we'll call it failure to make it
Hmm.
easy, put a bow on it. If you're afraid of failing your patient in that moment and you feel shame over the poll, it is a very normal human response. As you said, a lot of these issues are normal responses to maybe even retreat from the poll issue and get stuck dealing with the patient issues that you can resolve. This bed needs this, that, the other thing. I can't manage the poll issue, but I can do these. And then the patient who has this issue that can't be dealt with is feeling neglected. And I think it can just get stuck in this cycle of avoidance too, because then you've got an angry patient and that just makes that shame grow and grow and grow. So I'm curious to hear from your perspective. I know what that feels like as a doctor. And I know when you go over these incidents that I do feel that shame has so much to do with why a lot of these things grow and get out of control from a isolated incident to systemic issues as well.
Yeah, that's great. I'm so glad you brought in the word shame
Yeah.
because the experience is omnipresent, and yet
Mm.
I often do not think to bring up that word, even though um, we have a nurse anesthetist I know who talks about shame and blame. I mean, so we even have this rhyme, right, to
Yeah.
be mindful, and yet I don't think about it. But you're exactly right, and the IV pump thing continued with the charge nurse coming up to me later and saying, well, "Why hasn't that chemo started?" And I said, "Supply can't give me an IV pump." And she said, "Well, I've never heard that excuse before for not starting chemo." And,
Mm.
I had learned from experience, right? Don't don't even comment, just let it go. But how unfair is that? Like, I didn't create this scenario. And also, what is she doing? Why doesn't she get me an
Mm.
IV pump?
Yeah, and that's
You
again,
know?
are we focused on solving the problem or are we
Right.
focused on, in a way, kind of airing our feelings about the problem? And that's not necessarily a bad thing, but shame is never a good thing. We can air our frustrations. We can say, "Oh, that's really frustrating that we have this supply issue." Like we can say, "I'm frustrated," without saying
Right.
trying to kind of um take that frustration and use it as a stick against someone else, which I think is just something that so often happens. And then the bruise just gets bigger and bigger and bigger, and it spreads to more and more team members. And we're not solving the problem. We're just kind of recovering from this pain. And then how can you show up the best for your patient? So I think
Right.
it's the systemic issues in medicine. They don't excuse not having empathy for patients in any way, shape, or form. That being said, when you have moral injury, which is what burnout really is, right? We use
Right.
this amorphous term burnout, but it really means that people who are suffering from quote unquote burnout, they have a moral injury that's coming from a variety of reasons. And in healthcare, it's really rampant. So if we have a group of individuals that are suffering from moral injury and it's being compounded by not truly resolving the issue, then they're injured. They can't show up for their patients in their wholest, best self to do the best work for them. And so I wanted to ask you, reflecting back on your book and your experiences, your speaking, I know you've had amazing conversations with other healthcare professionals about the book, about your experiences. What are some really significant systemic issues that are impacting the nursing field? And what are some potential solutions that institutions, groups, colleagues can implement to really initiate positive change?
Great question. So, in my book, The Shift, not just a day in the life of the hospital, but all the life in a day in the hospital.
Yeah.
And one thing that I got asked about over and over and over again in radio interviews that really surprised me, and these were not technical people for the most part. I mean, it was, pick a radio station, right? And that person was interviewing me, or NPR, whatever it was, asked about nurses working 12-hour shifts. And I had no idea the public knew about that, thought about that. People worried about that.
Yeah.
And I said to them, yeah, the data is clear that mistakes go up, certainly after 8 hours and definitely after 10 hours. And you probably know this true from your medical training. So that quite surprised me talking with people just about having 12-hour shifts. And the bonus of having them, I would say, is that you don't have to worry about balls being dropped. So you have people for the whole day, but yet that's also its own form of self-delusion, right?
Mm,
Because we know statistically that mistakes go up. So statistically, it's more likely that you will drop a ball because you're just too tired. So there was that. And then the subtitle of the book is One Nurse, 12 Hours, Four Patients' Lives. So I gave people these questions, like right with the title of the book,
yeah.
but also the for patients. And if the public doesn't know this, a huge issue that was true in healthcare before the pandemic and has just gotten exacerbated post pandemic is nurses having more patients than they can adequately care for. And this also is very, very well documented that above a certain number of patients, depending on the floor and how sick the patients are, patients will die who would not have otherwise. And I wrote about this for the New York Times over 10 years ago. And I thought, great, now people are going to know because Linda Aiken at Penn, who's done a lot of this research, had a new study coming out definitively showed this. And it just goes in one ear and out the other because hospital systems see nurses as the largest employment group in any hospital, which they are. And so if you want to control costs, you limit the number of nurses that you have. And the problem is that not only do more patients die if you don't have enough nurses, but more patients get urinary tract infections, more patients fall, more patients don't recover well after surgery. All these things that cost money, but they're all different pots of money.
Mm.
And I think that's another thing the public doesn't really understand. And I mean, I didn't even understand it until I started learning about the financing of healthcare, just the complexity of payment models and funding and who's paying for what is just unbelievable. It's an unbelievable layer of complexity. And so I've given you a very long answer.
No,
Um,
I love it.
but it really gets to nurses are just having to take care of more patients than they can safely care for. And you are exactly right, Shafer. This leads to moral injury, which more colloquially we're calling burnout, and it's just a very vicious cycle. And it's a shame because there are so many wonderful nurses and also wonderful physicians who are just finding the conditions very difficult to tolerate.
Yeah. Or even untenable.
Yes, also, yes. I didn't want to go
Even
there, but you're right.
untenable.
That's true.
Yeah.
That's true.
Yeah.
Yeah.
And I think it's, you know, we have to pay attention to both. Both. We know that prevention of a problem is the best thing we can do, whether it's in medicine or in employment. We want to retain our employees. But it goes back to what you said that, you thought, okay, there's this study out. I'm going to one of the biggest news agencies in the world, with such wonderful
Mm-hmm.
reach and such wonderful fan base. I'm going to get this story out there. It's going to really, people are going to know better, so they're going to do better. But you still met friction. And it feels like, and correct me if I'm wrong, that friction was monetary, right? It was based on what is this a cost-effective strategy? Does the cost of having 8-hour shifts, does it outweigh the
Mm.
benefits to our institution of the safety? And I think, it's interesting because anyone who's worked in a hospital or even had the unfortunate opportunity to be in a hospital because they had an accident or something, you've probably noticed on the unit you stayed on or worked in that there's a sign often that says blank days since the last fall,
Yes.
right? So that's that reminder also to the nurses who are overworked and they have, potentially too many patients for the safest implementation of all the things that they need to do for their patients during the day and for the institution. I know you've talked about, charting and all the things that just simply
Mm,
have to be done for billing purposes, for safety monitoring, all of those things. So you've got this big sign and it says it's been 36 days, 90 days since a fall, and then oops, back to 0 and then 1 and 2.
yes.
Um, and the question, is that a motivator or is that, another shamer? So not only do we have that element of, again, almost fear from the employees,
Hmm.
that tool, some people may see it as a motivator. And they say, no, 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 Dr. Shafer, that's going to motivate people. They want to keep that at, 90 days. They don't want it to go back to 0 days since last fall. But I think it's not just or correct to say we're going to monitor really closely how well you prevent falls as an institution, as a group of nurses and aides. But we're going to put you in a situation where you can't monitor patients. And,
Yes.
you have patients that maybe need to go to the bathroom and they don't have a Foley, but they shouldn't get up, right? Because maybe they pulled their Foley. There can be so many scenarios that lead to an urgency with a patient and they get up, even if they have a bed alarm, et cetera, et cetera. And then you also think about what happens when we use a lot of bed alarms, right?
Mm.
And we kind of force people to stay in bed maybe more than we would if we had more support and we had them getting up more. How would that affect their health outcomes and their bounce back to the hospital because they weren't getting bed sores or UTIs or things because they were or DVTs because they were simply moving more, which we know the body is made to move. So I think it's really problematic, honestly, when you are measuring and making very public, this falls scenario, but you're not empowering people with the tools they need to avoid that scenario and keep patients safe.
Now that this is a great example, and it's such a great microcosmic example because people have a sense of what it means to fall, right? It's very easy to understand. And I'm thinking of a situation where I came on shift and I was given a patient who had metastatic cancer in his cerebellum. This is the back part of our brain that controls balance. So this guy was a textbook fall risk. He had disease in his cerebellum. And yet, and you know how this goes, Dr. Shafer, there was no one who could come and be a sitter, what we call a sitter, in his room. And so they told me, well, just put your computer right outside his room.
Mm.
But and he had no judgment. So he was constantly getting up out of bed. And I did have other patients, believe it or not. And wow, imagine this, he fell. And which is it's sad. He was okay. And then he did get a sitter and they did put things in place to keep him from falling. But I got a call the hospital had put in place something like the fall investigative service or something.
Fallen
And
call.
yeah, something. Yeah. And that's good. And they called me and said, this guy's on a lot of narcotics and we're really lecturing me. Like, first of all, I don't order drugs. I didn't
Yeah.
order the medications. But finally, I just cut him off and I said, this patient has mets to his cerebellum. He cannot balance.
Yeah.
The unbelievableness of, okay, we're not going to have someone in his room when we know he can't exercise any kind of judgment. We know
Yeah.
he cannot balance, like he
Yeah.
cannot balance.
Yeah.
And then someone is going to call me and say that somehow this is my fault. And, I knew it wasn't and I handled it, but obviously I'm still upset about it several years later.
Yeah.
And to be set up to fail when you're taking care of people who are so sick and so fragile and who deserve better is terrible. It feels so bad. It really does.
Yeah. And then it causes another moral injury increases the shame burden that you're carrying, and it doesn't move you towards resolution. It doesn't move you towards,
Mm.
so I wonder what would it have been like if they called you and they were, instead of furious. And I talk about this. Recently have a book out about a little boy who really struggles with transitions and
Mm.
external demands. He has pathological demand avoidance.
Oh,
Um,
wow.
and so, there's a way we can communicate and stay curious instead of furious, even in the face of problems and challenges, small and big. And so if that administrator or investigator was curious about, gosh, what do you think? They basically teamed up with you and they were like, gosh, Theresa, what do you think contributed to this fall? And they were just open like that. Would that have allowed you to let go of frustration and probably shame? Because even though you knew it wasn't your fault, we're so conditioned to put on that shame and burden ourselves with it.
Hmm.
If they had been curious, could that have led to changes that help that patient and that would help future patients, right? Like, okay, maybe we have volunteers for the hospital that want to help, but we haven't figured out a place to put them. Tapping into the human need to help and empathy and pairing them up as sitters, because honestly, that's such a wonderful, if we're sick and in the hospital and we're not in, some people are in horrific pain and they want to be alone, but many people feel so alone and isolated in the hospital. And it is such a gift to have someone there sitting next to you, just holding space for you and acknowledging what you're experiencing. And it's interesting because as a physician, you feel that ache and that need when you go to see patients, and you've got maybe 22 patients on your
Yeah.
inpatient list. And then you also have maybe 8 to 16 outpatients on your outpatient schedule that day. And you're also getting paged by maybe 4 or 5 regional hospitals and you're reading EEGs, all those things. And yet you enter into someone's room that feels really isolated, even though they're surrounded by,
Hmm.
wonderful professionals who truly care about them. They're looking over all their stats, they're monitoring everything, they're trying to keep them in as much of a homeostasis or balance of their bodily functions as possible, getting them their meds, their meals, all of those things. And yet they feel so alone and so unseen and
Mm.
so uncared for because the human needs weren't met. The bodily needs were met, but the care of the healthcare felt missing. And so you as a physician, and this is where that shame and blame and time management also comes in. You as a physician come in and you're like, oh man, you're trying to be very empathetic and give them that feeling of being seen. But so many physicians are under so much stress to go and meet these things that we call RVUs, basically have enough
Mm.
beans in your bowl for the day that you've collected for yourself in the institution, that they can struggle with meeting that need.
Yeah, I have a good friend who's a very good primary care doctor, and she was telling me her job basically feels like, if you know that Claire Booth Luce quotation where she said, "No good deed shall go unpunished."
Hmm.
Um, because she said, if I spend extra time with someone, she is supposed to have the proverbial 15 minutes, and if she goes beyond that, it means everyone is late. It has a ripple effect all down the line. She ends up staying late. She gets dinged for that. She gets
Hmm.
dinged for all these people being late. And there's no reward for spending 10 extra minutes with that person who can't manage their CHF, or they're just struggling with life because their healthcare issues are so difficult, or whatever is going on. And I could tell that was so hard for her. I mean, it almost seemed like the soul of what got her into medicine was being slowly killed off in her body, which sounds very dramatic, but I really think it's important for people listening who aren't in healthcare to understand that if a nurse isn't there for you, if a physician you feel like is giving you the bum's rush after 15 minutes, it's not because those people don't want to be there. It's because they're working within a system that, as you just said, Dr. Shafer, puts incredible pressure on you to meet these metrics. And it's so difficult because far and away, everyone I've met who goes into healthcare does it because they want to serve, they want to help people, they want to make the world a better place. And it's becoming much, much harder to do that consistently if things come up that are quote unquote out of the ordinary. And things always come up that are out of the ordinary. Always.
Yeah.
It's because we're human, right? We're all human.
Right. There's the algorithm often doesn't tell you everything you need to know. And the more we are hyper fixated on algorithms, the less we're comfortable in the gray areas. And the thing is,
Ah,
life is full of gray areas. And for me, that's something I always thought about seeing patients as a neurologist. Neurologists have to be really, they have to know all the black, they have to know all the white, but they have to be really comfortable in the gray
yeah.
because there's a lot of gray, literally gray matter, but there's a lot of gray area and you have to be comfortable there. And I think when you get too hyper focused on algorithms and you become less flexible, less
Mm.
responsive to what's really playing out in front of you. We know that for success in life, flexibility is one of the highest markers of
Oh,
being
wow.
successful. Being rigid is not a sign of mental health or success. We kind of think it is. We imagine these people that they eat the same breakfast every,
Mhm.
morning at the same time, and they get up and they're very rigid, and so they're so successful. But actually when you look at, life, the people who are happy and healthy, they have a lot of ability to be flexible. And when systems get too big or they have too much monitoring or external control it's kind of outside the body, it almost takes me to an abuse. We talk a lot about abusive relationships on the show because I'm a really big advocate for understanding abuse as a health professional, because I think it affects everyone's health and family dynamics in ways that we often aren't trained to understand and acknowledge in medicine. But abuse doesn't work for our health because it's an external force upon us, right? That's why it is so injurious, not only to our body, but to our personhood, because our autonomy is taken away.
Ah.
Often when you have these really big systems, these regulatory systems, et cetera, or maybe you've got a hospital, a small community hospital that the docs and the nurses, like, they live in their community. They've been there forever, right? We're in Pittsburgh. Like, we know our people. We know what they need.
Mm.
But now it's bought up by, maybe an East Coast entity that, they're in New York City and they're here and there and they're in Raleigh, and they don't know as well as we do what our institution needs. But now we have to change everything because this is the way they do things. When you have something externally that's putting too much control without flexibility that responds to your actual circumstances, I think that can be really problematic. And I want your insight, because I think in some ways physicians have a little more latitude in how we can navigate things. Um, how is that in the on the wards for nurses with all of the regulations, all of the check boxes? Does it feel like you have the flexibility to respond, or does that sometimes feel like a bit of a bottleneck or a jumping off point for some problems to emerge?
I think it does make it harder to respond. And there's also the unspoken but very present sense of the hospital hierarchy.
Mm,
And um, when starting out as a new nurse, you'll hear about, that nurse who everyone listens to, and you
mm,
want to be that nurse. And then after I'd been there for a while, I was one of those nurses who I would say, wait a minute, let's look at this. And that's great, right? But there's a tremendous amount of stress that comes with being that person,
mm,
because I'm butting up heads against the hierarchy.
Mm,
I think I know this doctor and I think he or she is going to listen to me. And sometimes I knew they would listen to me. Other times it was much riskier, felt much less comfortable. And that's very, very difficult. Instead of having a situation where we're all on the team, we hear the word team a lot in healthcare, but there's much more a captain of the ship model, to totally mix metaphors.
mm,
And so that's hard. And what I liked about home hospice is I was the nurse out in the field, and it's nurses are the team, really the essence of the team, even though there are other members of the team, and the teams really are actually teams.
mm,
But the nurses are the main point people for the patients, and you call the physician, and here's what's going on, and our docs would say, "What do you want to do? What do you think?" And
mhm,
it was so different from being in the hospital, where somebody might get into a power struggle with you over ordering,
mm,
Tums for someone, for goodness
mm.
sake.
Yeah.
And I know hospice nurses who say they would never go back to the bedside because they had so much more clinical autonomy. But
Mm,
also, I realize, talking to you now, respect for their judgment.
yeah.
And, if there was a decision that clearly the doctor needs to make this decision, like what kind of antibiotic are we going to treat an infection with? I'm not going to decide that. I don't know that. But there are
Mhm.
lots of things hospice nurses know that have to do with prescribing, switching people on enough pain medication, and to work with physicians who said, yeah, you're there. You're the one with eyes on the patient. Tell me, let's talk about it together.
Yeah.
Um, and that's so much harder to get in the hospital. Although I will make a plug for the new generation of physicians. They just in general seem much more egalitarian, much less about hierarchy, much more about let's get the job done together.
Mm.
And it could be a real pleasure to work with interns and residents and fellows, because it did feel like a team. It felt like we really were here to take care of the patient together.
Yeah. And if you are coming through your nursing school, you're a physician assistant, you're going through that schooling, or going through medical school or osteopathic school, even if the trend is to have that totalitarian approach and to not be a team leader, you can reclaim your story. And that's something we talk about a lot here on the show. This is your story, and you get to set the tone, right? You don't
Mm.
have to maintain that. And I remember when I started in a small community hospital, and I was kind of that new generation of physicians coming in, and I was, we covered 22 county service area. So there was
Wow.
a lot to take care of as one person when you were on call. And, the nursing staff was incredible, and they were so respectful of your time, and they had really great instincts and really wonderful insights. The thing that really scared me slash broke my heart when I was first starting to take the calls was they would say, Doctor, I'm so, so sorry for calling you, but I just really wanted, and I would say, please never apologize for calling me, because
Wow.
I know if you're calling me, there's a reason. And, sometimes maybe someone hasn't figured out why they're calling you yet, but they're listening to their gut. Like something's wrong with the
Mm.
patient. Thank you. I will never be upset with you for listening to your intuition, even if you don't clearly know, and they had received feedback of, what are you calling me for? Just do it, just follow the order. Well, but they're calling you because something's not clear, right? And I think questions are always important and necessary. And if you're getting a lot of questions after hours, maybe it's because you're not, maybe
Yeah.
We need to communicate better. Maybe that's the issue, or maybe someone else on the team needs to communicate better. Well, like, again, let's be solutions focused rather than shame focused on dealing with this time management issue if that's all it is. But I think most of the time it's intuition and knowing something's not right. And I want to know that as soon as possible. I don't want anyone to sweep that under the rug because they're afraid to call me. And so I love having conversations like this to talk about what that feels like from both sides and say, again, like, you get to
Mm.
decide how you want to approach this. And even if someone has the wrong tone with you, you you can decide to kind of put your stake in the sand and say, "Oh, no, I'm going to be curious and not fear. Even if you're furious with me, I'm going to be curious and I'm going to reset the tone and I'm going to activate your mirror neurons and try to reset this and say like, oh, maybe docs had a really bad day or maybe nurses had
Hmm.
a really bad day and they're showing up upset to this engagement. How can I turn the tide? We can deal with maybe the inappropriateness later because it should be dealt with, right? We should always be
Hmm.
respectful to one another. But like if they're calling me and there's an issue, okay, let's get to the heart of the issue, right? And so I think there's so many opportunities for us as colleagues to learn how to communicate in the best professional ways, but also how to recognize the humanity, which is really what you started with. You know, we were talking at the top about, you know, we're all humans coming to work and we're going to have tough days and we're not always going to show up our best. How can we be buddies to one another? How can we be friends to one another in those moments beyond being colleagues? And that's where, again, the care and healthcare amongst team members, as well as from patient and caregivers, I think that's where we have a lot of algorithms to make sure we're providing, you know, we're getting the data and providing the medicines properly. And we know when to take the blood pressure, et cetera, and when to put on um, the inflatable things on the legs. I don't want to use like too many technical
Right,
terms on
right,
the show
right.
to help with prevention of DVTs, right? We know all that stuff. Do we know when to just quietly wait and listen so someone shares the really important thing that they're afraid to say?
Right. Yeah, and you make such a good point about sometimes the lack of interprofessional communication. You know, if physicians feel like nurses are calling them for things that they don't need to be called for, then, you know, the way to handle that, right, is to go to the nurse manager to say, can we talk about this? I would like to
Mm,
work this out. And, you know, it just, it doesn't happen. And if nurses have a hard time communicating with one particular doctor, it's very difficult to get any kind of communication going about, well, how could this be better? And I find that so frustrating. And even within
mm,
nursing, it can be the same. I remember at one point we were having trouble staffing the weekends. And so it's one of the charge nurses, who I think was the same charge nurse who came to me and said, well, I've never heard that excuse came up before. But she said, well, we're just going to tell people they have to work the weekends. And I said, why don't you ask people? I said,
mm,
people don't know that there are these spots. Nobody wants the floor to be understaffed. Nobody wants that. We all want our patients cared for, but I cannot volunteer to work a shift I do not know needs nurses. And, you know, so lo and behold, they ask people and people volunteer, which isn't to say
communication.
like, oh, I'm a
Communication is
genius.
key.
It's
Yeah.
more that there was no thinking that this could be something that brings us together as a unit and makes us feel like we're cohesive and we actually care what goes on here, rather than we're just going to bully people into staffing appropriately, which, you know, is not going to make anyone happy or feel like they want to be at work that day.
Mm,
um, so the lack of psychology, if you even want to get down to a sort of basic like business school idea of sort of how do
mm,
you manage people, you know, make people feel empowered, make them feel like they're part of something. Everybody wants that. And it's unfortunate that in healthcare, that's not seen as part of the caring for each other, as you put it so well.
But you know what it made me when you were talking about that? It reminded me, again, just going back to the basics of the psychology and really integrating respect and
Mm,
getting some good communication skills and teams, I think could be such a game changer, focusing not on the, you messed up when you did this, but like, hey, let's learn how to be good communicators and let's actually celebrate how it feels when we do it. The thing that I remembered was, and I imagine your hospital that you were most recently working at had this, what they started to do, there was so little respect for nurses' time and mental energy and burden and load that they realized when they were at the Pyxis, which is the machine that they go to get the
mm,
medications that have been ordered, they realized that the nurses got spoken to a lot and interrupted a lot because they couldn't even have, the 30 seconds to get medications out of the Pyxis, which is a critical moment. There are many medication errors in our country and across the world. And that is a critical moment to make sure everything, she's got to do her checks, right? To make sure that
hmm
she or he is getting the right medication, the right dose, the right name, date of birth, all of those things. And what a lot of hospitals started doing was putting red tape around where your feet would go when you stand in front of the Pyxis and telling people this is the no-go zone. If someone is standing here, you cannot
uh
talk to them because it's dangerous. But I think yes, it's really interesting and it might solve the problem, but it doesn't solve the grander problem, which is that we need to respect that that this person has boundaries and we can't just go and bark orders at them and expect them to do a lot of things that maybe they don't have the time to do or they don't have the training to do. And they're not necessarily going to feel empowered to say, hey, I'm actually not trained on that. Go to this person because they don't even have a moment. Because again, they're by the Pyxis doing something really, really important. So again, this conversation really makes me think about getting back to if we're really wanting to make things better for patients and for healthcare providers, is coming back to that empathy and mutual respect and quality communication.
Yeah, and you're also making me think about something that I know you understand very well as a neurologist, which is that nobody can actually do two things at once. In our brains, there is no such thing as multitasking. And yet, in healthcare and many fields, we continue to believe that we can. But yeah, how many times was I pulling a narcotic into a syringe or um, doing all kinds of things with medications that really needed my absolute full and complete attention? And I got a phone call, someone stopped to talk to me, and it's not good for patients, and it's also just not good for our mental load, the
Mm,
mental load we have to put up with at work. And I know doctors go through the same thing. I mean, there's a moment in my book, The Shift, where I talk about shadowing in the ED as a nursing student, and it was actually a neurology. He might have been a fellow or a resident. For people listening, sort of, it's a degree of doctor in training,
mm,
and he was actually doing a craniotomy. So he's drilling a hole in someone's head because they had a brain bleed, and he's trying to release pressure on the brain, getting constantly paged while he's doing this craniotomy. He looked like the most exhausted person I have ever seen in my life. His scrubs didn't fit. And
mm,
here he has this tremendous level of responsibility. And uh, he finally asked the nurse, please just write down the numbers that are coming up on the pager
mm.
so he could at least ignore it. Finish the
Yes.
craniotomy, picks up the list of phone numbers and starts dialing. And I thought, oh my God. I mean, maybe this guy had had the absolute worst day of his professional life. It happens to everyone, right? But it made such an impression on me what we expect of people.
Mm.
And how can anyone be at their best or even average in
Yeah.
a situation like that? And you're
Yeah.
drilling a hole in someone's head.
Yeah, and then you're really leaning on your physical training, because when it comes to procedures, thank God, the amount that you've done something is so helpful, and that's
Mm,
our saving grace. That's why you can still put in the IV when you're exhausted at 10 hours, because, well, my
uh,
hands have done this thousands of times, right? And that's our saving grace. That's why the whole thing doesn't fall apart. But as you said earlier, I mean, of course, it increases mistakes. And how many people have had not only errors in the hospital, but gotten into car accidents on the way home after they've, been working for 24 or 36 hours on a shift. I mean, and there are new regulations that try to help protect residents, which is fantastic and so necessary. Um, and those go away once you're employed, right? That you don't have, there are no guardrails anymore. And so it's really up to the institution to ensure that they're practicing safely with regards to their staffing ratios. But they meet their own issues with regards to even finding people to fill those positions, and it just kind of comes to, what do we do now? And I wonder if that is partly the answer to the question I want to ask you about. So when you decided to start writing your incredible books that they're written in such a way they're very connecting with people, which I think is really
well, thanks.
important. I think that's really unique. And my opinion would be that has something to do with how wildly successful they've been, is in part people can hear that human voice. They can hear the caring in your writing,
Mm,
and we're aching for that. We're aching to connect with people in medicine, because we've all had those experiences in medicine. We've all needed healthcare, and I think many of us have felt a bit brokenhearted because we have this
mm.
idea of what a doctor is or what a hospital stay should be, and then we had an experience that maybe we felt was lacking. What inspired you to start sharing these stories with the world?
Fun question. Yeah, I looked at my writing as an opportunity to really educate the public about what nurses do, and maybe that reveals my background in teaching, since I have a PhD in English and taught in English department before I became a nurse. So I really looked at it as an opportunity that way when I started. And for a long time, actually, I had this sense of mission. I really thought of it that way because I feel like so many people don't know how important nurses are to quality healthcare. They think, influenced by Grey's Anatomy in particular, that all nurses do is walk around the hall carrying bedpans and say, "Can I help you, doctor?" And we actually have such an incredible level of responsibility. And the nurse is the eyes on at the front line, right? So the nurse is the one who calls the alarm, is the canary in the coal mine. So I felt that sense of mission. Now though, I really do want to create a vision of better healthcare. I went looking for hope in healthcare, and that's what I'm writing my newest book about. I'm in the middle of writing it, and I want to give people a sense that care in the U.S. could be better. We could actually have the best healthcare system in the world, which I think we used to, and now we don't. And there's plenty of data that shows that we do not have that anymore. I want to give people something to believe in, and I really hope that my writing has done that throughout. But that is my biggest goal for the book I'm working on now. I want to make the world a better place. I do. And that may sound like a cliche, but I really, really mean it. I feel it. And I'm hoping I can do that. Sure.
Theresa, I could talk to you all day, and I know our listeners have learned so much about you and the work you are doing to showcase the realities of life in the medical world, which is critical in empowering people to change systems, even those as deeply entrenched in longstanding cultures as medicine is, which we all have experienced either professionally or personally. What do you want to empower people in the medical field as well as patients to be aware of and potentially do their part, if inspired, to ask for positive change?
Yeah, that's a great question. And that's a really hard question in terms of meeting the need, I think, because I get this question a lot. And I wish I could just give everyone a sledgehammer or something to, like, let's just destroy the system. But I don't think that's the solution anyway. And it's not practical. So then when
Mm.
you get to what could people actually do? And what I've tried to show in my books is the good, the bad, and the ugly of healthcare. And I said that once to my chief nursing officer, and she really did not like that. Just
Mm.
she wants it all to be the good, right? There is
Mm.
bad sometimes, and there is ugly sometimes. And I think anyone who's dealt with the system knows that. So I would like to help people understand the texture of the system and how interconnected and interlayered everything is and how complicated it is. And there are a lot of moving parts. There are a lot of people. People can also become moving parts. And so the question is, how do you center yourself in that as a patient or a family member? And I think what most people sort of absorb implicitly is that they should just keep their head down and do what they're told. And sometimes that works, but sometimes it doesn't. And so then what do you do, right? And I'm getting to the nub of your question. And what I tell people is, learn as much as you can about your environment, your hospital system. That may not be possible. So in the moment, don't feel like your only option is to just keep your head down and shut up or be labeled the difficult patient. Ask for what you need. I tell people to deploy the phrase, I don't understand, and just keep saying that until you do, because that should get a nurse, a doctor, a physical therapist, someone to come in and talk to you. And so that you do understand why you're in the hospital, what your
Mm.
treatment plan is, or while you're in the doctor's office. And it's very, very hard because everyone is overworked. And that's another thing people should know. Everyone is overworked. They want to do their best, but they always have too much to do. And so you can yell and you can scream. And believe me, I had moments in my breast cancer treatment where I got really angry, and sometimes it works. It feels terrible though. So I'm trying to give people tools. Ask for explanations, ask for printed material if that's how you learn things. Ask for someone to come in and take the time to talk to you and explain what's being done. Ask the person who comes into your room who they are. You can do that. Um, ask to not be interrupted, say from 1 to 2 in the afternoon, because you just need an hour where you have privacy and some peace of mind. You can really ask for things you need that help you feel more in control, more empowered, more like a human being. And you can also fire physicians, even attendings, rounding attendings. I've seen this happen. If a doctor is very difficult for a patient, they can say, no, I'm not going to see that attending. You can also complain about nurses. The one thing I would caution people is keep in mind that most nurses these days have way too many patients than they can really safely care for. And so I encourage people to put those complaints in terms of the system. My nurse just seemed really overworked. It just seemed like the hospital wasn't making it possible for my nurse to really take care of me the way that would have been nice. You may have an individual who's just a bad apple, and then you complain about that person. But if people can try to complain about the system, this happened and this happened and this happened. And it just seemed like staff did not have the time they needed to treat me like a human being. And if more and more and more people said that, I think it would start to make a difference. I think it's hard to feel like each of our individual voices matters, but together they get loud.
Yes. Oh, I love that. And I love, anyone, if you haven't read Teresa's books, I so strongly recommend you do so. Even just listening to you speak, hearing how you use your words, and you really build an experience of what you are sharing. And I think that has so much to do with your incredible success of being able to connect readers with this medical world that maybe they've put a toe in, maybe they've had a family member involved in, or if
Mm,
they've been have some experiences too, to get a better understanding, to look behind the curtain so that it's no longer mystical. Because I think a lot of times we allow things to transpire in our lives in part because we see it as other and mystical. And what I hear you suggesting
mm,
is to see the individuals that are a part of that system as someone that you can connect with rather than focusing on, and this is something that I've done in my recent children's book, focusing on when we're in emotional moments or disconnecting moments, focusing on connection rather than correction, outside, of course, of situations where there's
oh,
abuse, right? When there's abuse, we need to correct that, right? And we can't ask them to treat us well because they're they know what they're doing. But when we're talking about a situation where, like you said, someone is just a part of the system, they're overworked, they're trying their best, but they're basically trying to drink out of a water fountain that is actually a fire hydrant.
right.
How can we connect with them on a human level to actually work on making the system work better? And like you said, the first thing is to add your voice, because the more voices we have, now we have a chorus and we will actually be
Mm,
heard. So many of us have been discouraged from using our voices, maybe in our homes and early lives and relationships at work. And so we have this limiting belief that we're carrying in that backpack of our experiences that might be
mm,
dimming our voices, bringing it down. I love so much your encouragement today and through your books to say, whether you work in medicine or you're a patient in medicine, we really need you to speak up and share your story so that we can turn this around, because we all feel this aching need for change, but we can't do it individually alone. We have to do it together.
yeah, that's beautiful. And yeah, I'll say something briefly about the book I'm working on right now, which is called For Nurses, is my search for hope in healthcare. In response to my own burnout, I decided to look for hope, and I found it. um, I'm looking at 4 places across the lifespan. So, a midwife standalone birthing center, a place that does in home primary care, a program called Capable that helps elders age in place, and then a hospice and palliative care program. And in each of these places, I've seen people working so hard to give great care that's very human and hands on, the way care really needs to be if it's going to be good. And they also all struggle to pay their bills because of the crazy, messed up incentives in our current system.
Mhm.
But what I'm hoping, there's that word, is that combination of seeing we could have great care, we need to have a system that supports it. And everyone says, "Oh, that ship is so big it can't be turned." It absolutely can be turned. We're Americans. We can do anything if we put our mind to it. And so I
Mm.
really want hope in healthcare to be a reality. That's my very small wish for my book.
Oh, I love it. And I'm so excited. Do you have a tentative launch date for that book yet, or is that secret?
I don't think I know that. I'm turning in the manuscript at the end of August, so that's what I'm
Oh,
focused on.
exciting.
And then they haven't decided on a pub date yet. Not because people should know, not because there's any kind of mystery. It's just balancing out a whole bunch of things, and it just takes time. Unless you're writing a book on, say,
Yes.
Trump, that you want to come out as quickly as possible. It takes time to do all the
Right.
work to make a manuscript, a
That's
book.
Yeah, that's another curtain to look behind. And that's in part
Yes.
why I asked, because I think it's really interesting. A lot of people don't necessarily know what goes behind writing a book. You write the book, but that's kind of the tip of the iceberg. There's a lot that goes on beneath the surface. And it's really intriguing to share that with people and have them understand what a work of love these contributions that you are making are,
Mm.
that you are sharing. And I so appreciate you really helping to inspire people to, in their ways and their lives, help be a part of putting the care back in healthcare, because it's not too big of a ship to turn around. But we all basically have to take our 2 oars that we have
Oh.
and put the energy in, right? It's not going to happen without every individual who is inspired to do so doing their part. Now, how can listeners connect with you, get the books you already have published, and make sure that they follow along so they don't miss your upcoming book?
Oh, great. Yeah, so I have a Substack newsletter that's called the Healing Newsletter, and you can find me at Substack. I'm not quite as regular with it as I'd like to be, but it is free. And I guess not always publishing regularly means I'm trying to always give you really good content. So you
Hmm.
can find me there. You can find me on Instagram. I think I'm Theresa Brown RN 2021. I'm on Blue Sky as Theresa Brown. And I also have a website, theresabrownrn.com. And you can find my books basically wherever books are sold. And you can also find links to them on my website. And there's also a way through my website that people can contact me if they want to. And I do love it when I hear from nurses, doctors, patients. And I do read all the messages. I'm not always able to write back, but I do really love hearing from people, and every message makes a difference to me. I love hearing everyone's stories, and then, as you say, doing my bit to encourage all of us to put our 2 oars in the water and move this ship of healthcare in a different direction.
Thank you so much, Teresa, for being here. This has been such an inspiring conversation. And thank you so much to our storytellers for joining us again today. If you haven't already, make sure you subscribe to Talks with Dr. Shafer, where you enjoy podcasts for more inspiring short talks to help you master your mindset, and weekly inspiring guest episodes, just like the one we just had with people who have reclaimed their stories, are living life to the fullest, and are here so generously sharing their stories with us. Teresa, thank you so much again for being here.
Oh, you're welcome. It was such a pleasure, and I appreciate you having me.
Thank you so much. And everyone, until next time, as always, stay safe and take care. I'll talk to you soon.